This is mostly just for me to review like how things went. So just trying to build towards a keynote talk of some kind. So we'll see. So bloodwork interpretation is the topic. Trying to work towards a notion of longevity, kind of, that I think is not talked about very much. And so trying to build the case that the hype cycle has got it wrong, and we can do a much better job of getting towards a better sense of what matters for longevity. So ultimately, yes. Perfect. Thank you. Yeah, we'll see. So I wanted to start off with, and I'm going to cover a lot of stuff that I probably covered on the channel already, but a little bit faster, hopefully. I wanted to start off with the concept of like the normal range. So where does that come from? And yes, I have doctor handwriting, so that's, yeah. And so it comes usually for most labs from just sampling thousands of people somewhat at random who have no apparent health issue and seeing where their labs are. It forms a bell curve, and that's the normal range. You take a 95 or 99% confidence interval and declare that to be normal. But of course, even in the sample you're testing, there are some people outside of that, right? That's what makes the frame. Like I always give this example of my mom. My mom has had a white blood cell count of like 11 or 10.8 for several decades. Like that's her normal, right? And she's been worked up because everybody's like, oh God, it's outside the normal range. You must be sick. There must be an infection. There must be, but there's not. It's just that's her normal. And so that is the first layer of confusion, right? Is that like, is she really normal? Is there a hidden issue? Is there something that just no one has detected, that she's got some sort of long-term risk? We don't know because we just sort of defined normal this way, which is a bit arbitrary. Like truly, like some of them use 95%, some of them use 99. Like it's a bit random, right? Then we have things like liver function tests, right? So we use AST and ALT, and that has a normal range. But in med school, we are taught to basically ignore anything unless it is 3 times the normal range, because no diseases that are relevant actually happen until that point. And so there's a normal range, and then there's what we care about from a disease standpoint, right? And I think this worked until we started kind of like, and it's not a bad thing, but it just creates an additional challenge of democratizing access to labs. Like my mom kind of talked about how you would get labs drawn, you would have no access to those until a physician set an appointment with you to discuss the results of those labs. So the interpretation came through the lens of someone who had this background. Whereas now we're just sort of like, you get access to your chart and you see a lab value that's here and it's abnormal. And so you can kind of freak out and say, maybe there's something wrong, maybe there's something going on, and maybe there is, but maybe there's not, right? And so those are the first kinds of things. There is another way that we get to the normal range, and I'm going to get there after the next section, which is related but not exactly the same, and that's the notion of a threshold. So I'm going to take thyroid as an example, and if you draw bell curves, and this, we use TSH for thyroid, which is a bit interesting in itself, just as an aside, because TSH is the hormone that comes from your brain to your thyroid to tell your thyroid to make thyroid. Now we can measure thyroid, but because it is relatively fine-grained, it's not as accurate or useful of a tool, whereas TSH takes 4 to 6 weeks to fluctuate. And so you get a level value of where your body overall thinks your thyroid function is, whereas if you're looking at the actual thyroid hormone, it'll fluctuate a lot more, and it takes longer to be abnormal, even for severe hypothyroidism. So anyway, those are, again, asides and tangents. When I was in medical school, sorry, and these curves are, these are all normal people, or normal people. people without thyroid problems, and these are people with low thyroid, hypothyroidism. As if God came down and said, okay, I'm going to put a blue hat on everybody with hypothyroidism. Anyway, when I was in med school, we used a cutoff, and this is TSH, we used a cutoff of 5.0 for TSH as the line of normal versus abnormal, right? And the issue here is that you end up with a certain number of false positives and a certain number of false negatives, right? And so there's no real way to avoid that, but what we have done since then is we have dropped the threshold to around 3.0. And we've decided sort of semi-culturally in medicine that we would rather have more false positives in order to get fewer false negatives, right? For this particular disease. Now we make other choices in other circumstances, right? Like, and different diseases, different tests have different characteristics. The nice thing is that, like the HIV test is sort of like this, right? And so you can pick a fairly easy one and you get relatively few both false positives and false negatives, but other tests are even worse than this. ANA, for instance, is very famously, it's kind of like, this. And you're like, well, I don't know. We pick a number, yeah.
I was going to say the false positives thing, is that like choosing a p-value of 0.1 instead of 0.05, you end up getting more false positives?
There's a great, yes, that's a great analogy.
But then I guess you would also, do you get less? I don't know how that
Yeah. No, so the exactly right. Actually, you can consider any study with a p-value to be a test, a medical test of the hypothesis of that study. The false positive rate is the p-value, and the false negative rate is the power of that study. So you'll see studies that say we're powered to 80%. That the standard here for power is 80%, p-value is 95%, or 0.05, right? And so that's basically giving you that this study has this result, supporting or denying the hypothesis, and this is the likelihood that that's either a false positive or a false negative.
Okay. And you'd rather err on the side of a false positive, right? Because then you can take some action.
So this is there's huge debate in science on this. When we were doing one study a year in any particular discipline, you wanted to err on the side of having more false positives because you didn't want to miss out on truth, right?
Exactly. Yeah.
Now we're in a situation where we're generating so many studies per year, we're not even tracking through all the false positives, no one's replicating it, and therefore we're getting a ton of false positives into the literature that are just sort of adopted as truth, even though, and actually, so this segues kind of nicely actually into the next section. John Ioannidis, who's like one of my favorite statisticians, he one of his big areas is the epidemiology of science studies. So he studies science and scientific literature. And one of his most famous papers is why most published research findings are false. And you can actually go through and say that given the volume of studies we're doing and these standards that are historical of 0.05, greater than 50% of published results at this point are likely to be false positives, right? So that's an interesting, and how we got there is a great way of getting into the next subject, which is, of course, pretest probability. So any given test, as we talked about right here, this thyroid test, has false positive rate and a false negative rate. You can combine those into likelihood ratio if it's positive and the likelihood ratio if it's negative, pretest probability, and you get a post-test probability. And the important thing here, and I'm going to go through all those terms, but the important thing here is if you give a man a pregnancy test and it's positive, you will come up with almost any explanation for how that happened except that he is carrying a fetus, right? Like, that's the lowest thing on your list. Lab messed up the samples, he has a tumor producing beta HCG, you'll take any explanation because the likelihood before you ran the test was so phenomenally low that even with a positive test, you should be extremely doubtful of the result, right? Another example I like to give is if I build some sort of cool AI machine, robot, reaches into a bag, plucks out a bag, and tells you whether the marble it gets is black or white, and I can tell you it's accurate 99% or X, Y, and Z, but if I give it a bag of all black marbles and it pops out and says it's white, well, it's guaranteed, it's a 100% chance that's machine error because there were no white marbles in the bag, right? Now, if I give it one white marble in a million and it pops out and says, oh, hey, it's white, it's still more likely that it's wrong than it found the 1 in a million white marble, right? It's not until we get into, oh, well, there's 10% white marbles or 50% white marbles, then a 99% accurate machine matters. But before that point, when you're talking about rare conditions, like a man being pregnant, the test doesn't really matter. And that's because this pretest, if it is low enough, even a very strong, like a high multiplier of a positive test here, you still end up with a pretty low value of post-test probability, right?
Just for mental model for everybody, does the negative side of that also lead to some post-test probability?
Yes, absolutely.
Okay, just
yeah.
making sure that there's a sort of analogy.
Totally.
At the bottom of the,
Yeah, totally. And so we'll go. I mean, let's take a real example, right? So I was talking about thyroid before, right? If you just take everyone and I just do a TSH on everyone, right? Well, the pretest probability is sort of the prevalence of hypothyroidism in the population. You say, well, you say, well, 1 out of 100 people is hypothyroid. So you're starting at 0.01, that's the baseline, right? Then those false positive, false negatives combine to give you this number, and you can figure out if you get a positive test, if you get a TSH that's over the threshold you've determined, how likely is it that that's real? How likely is it to be wrong? You can kind of figure that out. And of course, if you start shifting those thresholds, as we talked about, well, then these numbers change and the value of a false positive is higher or lower. If by contrast, instead of taking everyone, if I only test people that have constipation, low energy, weight gain, loss of hair on the lateral third of the eyebrow, all the symptoms of hypothyroidism, and I only test those people, well, then the pretest probability is much higher. Maybe 20 out of 100 people with all of those symptoms would be hypothyroid. And so the test will perform much better, right? So the accuracy of the test depends on who you're testing. And the analogy we were talking about with studies is if I'm testing improbable conclusions, well, if I use the standard 0.05 probability, it's very likely I'm going to get false positive results, right? Especially if I do enough of them.
Is there language that distinguishes the notion of accuracy from like effectiveness semantically from a testing perspective? Because what occurs to me is that you're talking about the instrument, right? The instrument isn't changing its accuracy as a function of the pretest probability.
Correct.
However, we interpret the result differently. So there's something
Correct.
So there, it's like the effectiveness or the perceived effectiveness of the test is what's changing there,
yes.
not the accuracy of the test itself.
And that's why actually I hate how the terminology has evolved. Yes, we use the term false positive rate, right, to reflect these numbers. Well, they both contribute, to be fair, right? We use false positive and false negative rate here to reflect the machine, like that thresholding kind of concept. Whereas this is the term no one's ever heard of, which is positive predictive value and correlatingly negative predictive value. So the terminology is weird, and you never hear those terms, partly because most doctors don't understand this either, right? It's baked into sort of the algorithms and the protocols, but the average physician on the ground cannot answer a question based on this correctly. And they've done studies on that, testing physicians, and they get wildly wrong. Like, you know.
It's also kind of hilarious that we've built a statistic on the right as a function of a statistic on the left, and neither of those numbers then is going to meaningfully apply to any one of the data points. And so
right.
You're kind of creating I mean, if one were to be hyper cynical, you'd be like, well, we've just created a nonsense thing from a nonsense thing. And it's like, okay, Like that's also very.
And that's a little bit the point of the talk, actually, is that like I mean, it's not complete nonsense,
Sure.
but it's way fuzzier than people give it credit for,
Sure.
right?
Yeah.
Like you have your thyroid level was high, and we take that as definitive in a way that it's just not, right? Like it just does not reflect what we think it does on many levels. Like already, okay, my TSH came back at 5.1. Well, am I just normal and I'm on the bell curve and I'm fine and there's nothing to do there? Or is that reflective? Like, is that a false positive because of the test? Or is it a false positive because of my I have no symptoms, so did it catch it early, or is it giving me am I in the, false positive result category? Well, already we're layers and layers of uncertainty, right? So let's go to the next layer. I recently, I don't know if everyone knows this, but I recently got curious about this topic. And so the next question was, how precise are these labs, right? And so I went and I put needle in, I drew 15 samples of just chemistry and testosterone level from the same vein and sent it to the lab under different names to see how wide the spread of results I got back was. And it was non-trivial, right? So potassium, the low normal is 3.5, the high normal is 5.4, and my results, I think, were on a peak of around 4.2, but the spread around it was 0.5. And again, it's gonna be a bell curve, right? And just because I got 15, mostly I was probably sampling from the middle of the bell curve. If I were able to give 1,000 samples, I'd be dead, but if I were able to do that, you would probably see a spread of around 1. And so plus or minus 0.5 on potassium. Testosterone, the predicted spread was around 90 points, so plus or minus 45. Like, that's another layer of confusion, right? Another layer of fuzziness to all of these terms.
So 0.5 over roughly an original normal value range of 2 is about 25%.
Correct.
With perspective to those.
Yeah,
That's a
exactly.
25%, variance just in your own blood, sending it to a single lab, possibly same machine, although that's a subtlety as well, but same lab at least, same draw at the same time. Like all things being equal, you get a 25% kind of bit of randomness.
Yep, just out of whatever, right? And so I was joking, I was like, if I wanted to make a video, I'd be like, I raised my testosterone by 40 points with this one weird trick. And the trick was, send the blood again, right?
Yeah.
So as an example of the scope of the problem.
Yes. Yes.
There you go.
One of my first projects in the real world work was to take 20,000 different possible lab results for Sutter Health, and there were 11 different lab companies that those potentially come back from, and to map every single one in the electronic health record onto a reference range, and then decide with a lab technician next to me whether or not we would link those two potassiums as being in the same reference range or distinctly, so that the physician could actually see whether or not the 4.0 value meant the same thing as another lab that was sending back a 4.0 value.
Correct.
And then in one lab, 4.0 might have been out of the reference or the normal range, and so it deserved an exclamation point, so the doctor would see that it was a high alert, versus the other one would not. So you could see 7 different potassium results. 3 of them could be high alert, but they would look like they're in the normal range for the other one, and so we couldn't put them on the same line. We had to have 7 potassium results be on different lines.
Yeah,
and the doctors were like, oh, well, I have to hover over it to see the reference range,
Yep.
otherwise I don't know what that number means.
Yep.
So that's a massive issue.
It's a huge issue, right? Because again, I did this single lab, presumably single machine, right? Whereas you start sending it to other labs that are using other machines that are calibrated differently. Well, what does a 4.0 mean in that context? It's extremely unclear, right? Then you start thinking about the fact, well, how did that lab, or any lab...
Think about this. What if the person that designed that system, like literally the analyst that got paid, X number of dollars, what if you put all the potassium results on the same line, and it was 4, 4, 4, 4, 4, and it looked flat, and the doctor's like, oh, you're consistent. But in reality, that was a wild difference.
Totally.
But that's a massive human error.
It's a tremendous issue, right?
That's a big
Yeah, exactly right.
I was making a decision at 22. That probably should not have happened.
I suspect if we look deeply into how these decisions were made, none of us would be very happy.
What's also crazy is that the normal range itself is using that very technique.
That's where I was going,
spread
right?
across all the instrumentation, all labs, and like
Yep.
it's already got
Yep.
baked in volatility.
The study that determined, hey, this is the 95% confidence interval, was using this technique. Samples were not run multiple times in most cases, right? In any cases, actually, that I'm aware of, but in most cases, for sure. So,
And if you did, everybody would have been okay because they would have gotten one result.
well, and so I kind of raised this thing in my video, and it was like, well, we see this normal range. What if everybody in the whole world truly has, if in a like God's eye view, a potassium of 4, and all we're detecting is machine error? Like that's all we know, right? And so we have these ideas of normal ranges and thresholds and whatever. To what degree is our determination there even relevant to
We could
the
probably
machine?
use dogs and they could just sniff it out,
It's got a stinky, right?
Yeah.
When the samples go to the lab, how many times are they tested?
Once.
Just once.
Just once, yeah.
And so then that is the result.
That is the result. Correct. And that, I mean, and
Or not
you know,
the result.
and these are things that are sort of incorporated into medical training, and then most doctors forget about and lose. Like, common test question. Every med student has had an attending ask them this. This patient has a sodium that's low. What is the most likely explanation? And the most likely explanation is lab error. That's your answer. Lab error, right? So if you get a result, you repeat the result. Like you check it again to try to sort of navigate this whole factor, right? But
That's brilliant. In fact, if you're a patient and you get a bill from the hospital,
yes,
it's wrong.
also correct. Also correct. That is also correct.
Brilliant.
Yeah. Yeah.
So
And
how often should you have blood work done to then determine what your normal is?
so I did it 15 at one time, right? But I also had done the experiment before. I ran 6 at a time. Then the next day I came back and ran it again and did a workout and then ran it again. And so in that first experiment, I had 6 samples that were concurrent, and then one the next day, and then one after a workout. And the spread on that was huge. I think the lowest value in that set of values was 381, and the highest was something like 534 or something like that, right? So in addition to, in addition to machine variance, there is truly also physiologic variance, right? So to like your normal when? Your normal in the morning? Your normal at what point in your cycle? Your normal at what point in the day? Pre-post workout? Mood? I don't know. What type of normal are we talking about, right? Like,
It was interesting on my last blood work that I did a few months ago. They also, part of it, especially with testing hormones, it depends on where I'm at in my cycle.
Yep.
In a month, that they determine during that part what is normal.
right?
So that was new to me. I never thought of it that way.
Yeah, yeah.
I bet there's variance. I bet the largest variance is whether or not your paycheck just hit your bank.
And so, yeah, I mean, all these levels of difference. Here's another, and I alluded to this a little bit with the liver function, but we'll make it a little more real with something like sugar. So like A1C, right? Pre-A1C, we were checking fasting blood sugars, right? And we said the normal range supposedly was like 70 to 95 or 99, right? Or let's say 100, just for funsies, right? And so over 100 was sort of abnormal by sampling the population. At that time, above 140 was all we could sort of detect whether there was damage happening. And so the definition of diabetes was sugars consistently on separate occasions above 140. And then we said, well, if we spread that out further, we would probably start seeing damage if it was consistently above 126. And there was some modeling involved in getting that number. And so, and we did the same thing with A1Cs. So, we say, okay, a normal A1C is up to 5.5, and then diabetes is 6.5, that's the cutoff, and in between there's sort of this unknown level, right? But if you take diabetics who have an A1C of 9 when they're diagnosed and you treat them, then you get to the minimum mortality at 7.5. That's where you minimize mortality with treatment. So where is the threshold for disease? At what point does disease start? Like at what point are they really, like when they're abnormal? When we think if you go long enough, this will become a problem? At the minimum mortality for treatment? Like, what's the definition? So this gets into sort of like, how do we even define diabetes? Like,
I like the conceptual analysis.
yeah.
I would say that it's when it starts negatively affecting the person, right, in some kind of detectable way, or, I don't know.
Sure, and that's a great frame. I would agree with that frame in many cases. However, it takes decades for diabetes to do its damage. So let's say you're at 6.6. Okay, so you're over that threshold. Theoretically, you're diabetic. Whatever. If you stay at that level, it could take 30 years for any. If you take everyone, and of course all of these are population based, right? So if you take everyone with a hemoglobin consistently 6.6 for 30 years, they will have a slightly increased risk of heart attack, stroke, death, etc. over that period, right? Compared to someone with a truly normal A1C. So here's the question. If you're 90 and you have an A1C of 6.6, are you diabetic? Because you're not going to last 30 years. So you won't see any increased damage.
Oh, I see.
So by the way that we came up with that definition, you would not be diabetic because you can't ever see damage from it.
Then we can come up with a different term, diabetic and diabetic prime, right? If it's two different concepts that we're trying to refer to, then we need a different term.
I would agree.
It's
It's
like
a-
a gradient as a function of your age and life expectancy.
That's exactly
He's
right.
over life expectancy, this guy. So
Yep,
it's like,
yep.
Is that where pre-diabetic comes from? Like there's like
Yeah, so we started calling this range pre-diabetic,
I mean, yeah,
which I a little bit object to, but yeah.
I think it's kind of meaningless. I think the moment that you just start having bad habits, you just
Should just be killed off immediately. This first cigarette smoked, just
no,
That's it.
Yeah,
no,
yeah.
the first, if you observe someone eating a gummy like a bear or something, immediately like pre-diabetic.
Yeah.
Then
Just
I'm
immediately.
100%
Yeah,
sure, I'm sorry,
yeah.
then I must be, because I
Yeah.
do nothing, pretty much nothing but sugar.
Yeah.
Okay.
Yeah, yeah.
Okay. Oh, yeah, 100%,
Yeah.
I guarantee it. 100%.
you gotta have more protein.
But yeah.
Oh, go ahead.
No, you raised the point of health status, right? So I mentioned age here, but what if you're 40 with stage 4 cancer and you have a hemoglobin of 9? Are you diabetic? Like, not really. Like, not in a meaningful way. But you kind of are, but you're kind of not. And so, again, it's like, I agree with the logic behind that definition, but that also has implications. Whereas, if you define diabetes this way, then that also leads to weird things, because we know that if you treat a 90-year-old, we know that you get worse outcomes trying to get them to an A1C less than 8. And so we don't even aim for 7.5 in people over 75. We aim for 8.0
The treatment hurts just as much as.
because the harms of treatment go up, right? So again, like even with something now, I'm talking about these numbers. Now project back that everything I just said has all the fuzziness that we just talked about. like even the result, oh, you are 8 point, are you? Because it's plus or minus 0.5. 0.5 in this plus or minus 0.5, right? Like we just, that, like that level of fuzziness. Yeah, I mean like that level of fuzziness is just insane in an environment where you're talking about trying to manage this, right?
So if you have enough of these indicators which have all that fuzziness, you should be required to pay a 50% income tax. Whereas if you don't have that number, you pay a 20% flat. And that makes up for the excessive healthcare spending that nobody else has any control over. And if you elect to join your wellness annual retreat for 3 months, where you sign a contract to commit to the behavior change, you get to drop back to that 20% for 1 year, and then you get to test and see if your variables come back down. So
Makes sense.
yeah, that's
Makes sense. Another little semantic point. when, this is something I take.
I like how you invented a wellness retreat I don't have, but okay, yeah, I will. I'll make it.
It's a tax model that is built.
Yeah.
on that,
It's a tax model built on a.
It's gonna take more resources to figure out your problems if you're above a large threshold of problems.
Yeah, in other words, what you're saying is, if you've ever had a gummy bear, 79% tax.
Yes.
All right, makes
Yeah.
But so
Yeah, no, I come at that from a politically a very different place, but yeah, I wouldn't agree with that.
If that was the case.
Yeah. No, it's,
But beyond the scope of the talk,
What do they
but
do to
that's.
cigarettes? They tax the crap out of them.
yeah.
People don't buy it.
Yeah.
No, but the elasticity of cigarettes is different because there's an addiction involved. So the elasticity, right?
Sure,
You're
is it
willing
addiction?
to pay more for something that, like, I'd be like, if they raise the price of chocolate or coffee, I'm still gonna buy it. Like, it's not very elastic for me, right?
Right.
To use the concept from
Yeah,
economics.
yeah.
Is
It's
it a
not-
75% tax?
Maybe eventually, but I guess what I'm saying is like, for certain, if people are addicted to something or if it's
Yeah.
part of their routine, they're willing to pay more up until, yeah, anyway, you get what I'm saying.
Yeah, no, I totally do. And actually, it's funny you raise cigarette smoking because that's I'm trying to work on a video, and since I'm working ideas out here, we'll talk about it. Like the standard of evidence for us deciding scientifically that cigarettes caused cancer or increased mortality would not be a standard of evidence we would accept today, like for some other substance, right? And so it's a weird thing because it's like I can show you evidence on a similar level of robustness that coffee extends lifespan by like a lot, right? But we wouldn't accept that standard today, and yet we did then. And the only way we happen to know we're right is because when we intervened, deaths dropped, right? And so we can see the effect of an intervention that we did very much as I mean, I don't know that people were conscious of this, but functioned like an experiment on the population, where we're like, well, let's try and reduce cigarette intake and see what drops, right? But that, again, like, I don't know if you're willing to start like force feeding people coffee. Like there's other consequences in some sense. And so, yeah, I think that's the last bit that I'll say is, in my thyroid example, right, is, okay, my thyroid is 5.1. We're not sure if, is that false positive? Is it an error? Is it whatever?
Is it
Maybe
hereditary?
Sorry?
Is it hereditary?
There is a genetic component because it's the most common form is autoimmune, and so those tend to track, right? Also female predominance for that reason. So y'all's immune systems are just complicated. Well, no, which is interesting, right? Because the reason a woman's immune system has to be more complicated is because when you're pregnant, you have to not attack the baby because it's foreign. It's not your DNA. And so there has to be a shift in the entire immune system process to accommodate a non-you, but I'm not supposed to kill it. Because ordinarily it's like, not you, kill it, done.
It really,
Yeah.
it really stinks that like so much of our biology is predicated on this one thing that like more and more of us are never gonna do. Like literally every month I have the consequences of something that I'm never even gonna do. Great. Take it out of me.
Evolution's a
This is
bitch.
not the point.
It's, yeah. I mean, and I talk about this too, is that like the challenge is like there, as far as I know, we don't have any evidence of any species that evolve sexual dimorphism and unevolve it, because it's such a profoundly beneficial thing to have a group of people where you can conserve, like the mutation rate in men is much higher, right? Even neonates. So the neonatal death rate, toddler death rate, child death rate, adolescent death rate, adult death rate of men is just higher across the board, right? And part of that is biologically, nature has a conserved class and an experimental class. And so, the notion there is, hey, we'll keep this steady for the current environment, then you fuckers go out and kill yourselves, compete with each other and the environment, and whichever one of you survives will be allowed to reproduce, and thus I get the benefits both of experimentation and the benefits of conservatism. And in many ways, our culture, I think, tends to mimic that, right? And so, sorry?
Bees. We know we lost bees.
Yeah, explore, exploit. Yeah.
Oh, I've heard explore,
Also
exploit.
Yep,
birds, is that
yep,
the
yep.
idea? Birds and bees?
This is the crossover actually between those. That's
By the way,
yeah.
nature must be a bastard, not a bitch, because I don't think a woman would have done that to herself in general. That's, you know. By the way, okay, now that we're sufficiently off track, I won't feel guilty about injecting the following notion. So one of my pet peeves, as you know, is that may be relevant to this discussion. I think it supports the general sort of arc, is this idea that I think we abuse or misinterpret, depending on which side of it you want to be on, the idea of risk. So we use terms like, you know.
I prefer abuse, but yes, okay.
Sure, yeah,
correct. There's more pain, sadness, general suffering, and chaos involved. Yeah.
The notion of risk, the risk semantic, and we use terms like you use. I'm not saying this is right.
Yeah.
We use terms like, you know, given this number, you are at greater risk. That statement is false, depending on how you understand the notion of risk. If you interpret it as there, like something is wrong with me that is going to give me a higher probability of getting sick, then that is a false statement. If you say that given the distribution of this in the population, people who have this number have a higher probability, then it's a true statement. The point is what I made earlier, essentially, is that the notion of risk, usually in these contexts, and how we apply it, applies to a distribution of people, not to an individual. But the semantics we use are targeted at an individual, and that is absolutely not correct. I can't say you are at higher risk or whatever. No, you're not. You either have the problem or you don't, right?
Yeah.
Like if I took 1 million people and they had that number, I could say something meaningful about the distribution of the outcomes. But I can't say anything about you. You could be on the far left of that bell curve and have absolutely nothing wrong with you despite the number. And so the notion that you are at risk is just false. And I don't like the semantic. That's my position. It's not it gives you the wrong impression, I should say. Maybe that's the better way of saying it.
I feel like people sometimes say, okay, it's either raining or it's not, so there's always a 50% chance of raining and 50% not. But that's not true. It's not that just because there are two choices that the probability of each is exactly 50%.
I agree.
That's not true.
And that's not what I'm saying.
Okay, so can you explain, sorry, one more time?
Yes. So let's suppose you had, the number 5.1. What is it? Potassium, sodium, whatever.
I was talking about thyroid, but yeah, whatever it is. Okay.
Yeah, so thyroid signaling hormone, TSH, is that what
TSH, yeah. Okay. Stimulating.
Stimulating, okay.
Yeah.
Let's say your TSH was at this kind of line, this marker, right? The question is, are you in your life, are you at greater risk, whatever that means to you, of getting, of hyperthyroidism? And the answer is, well, you don't know. You're not at higher risk. What the statement of risk means in that context is, if we had 1 million people who had this number, more of them would get sort of hypothyroid than would not, would eventually kind of develop the disease. And that's the statement of risk. The statement of risk says nothing about you. It might turn out that you will never get it, and it may turn out that because of who you are, and despite that number, you would never have gotten it, and you just will never get it. And so you are not at any greater risk.
Wait, so you're saying we can't really make meaningful statements about an individual's level of risk for a certain outcome?
I'm saying that most people misinterpret the statement, you are at higher risk. They don't realize that what that statement actually means is, given I'll just use a number, given 1 million people, X percent of them get the disease.
Got it.
Given 1 million people who have that number, that blood number, that measurement, the X percent of them get this disease. That's what it really means. It doesn't mean that you specifically are at any higher risk.
But if you're part of 1 million people, and there's a X 50% risk versus 60% risk, you could be at higher risk depending on that.
Again, it depends on how you're interpreting the word risk.
Actually,
when I say you are at higher risk, right? You tend to think that you have some higher chance, if you will,
if
and
I
that is not
smoke,
true.
I'm at a higher risk for lung cancer, right? That's a fair statement to say. If I smoke, I'm at higher risk of lung cancer than if I don't
Again,
smoke.
it depends on. So I think maybe the confusion is what's the definition of risk?
I have a higher likelihood of getting lung cancer.
What do you mean by
I
higher
smoke.
likelihood?
It is more there are more scenarios in which I do get lung cancer if I smoke.
You or people in general?
Me.
Okay, no, that's not true.
So you're saying it's not the case that if I smoke, I am at a higher likelihood of developing.
It depends on what you mean by higher likelihood. That's my whole point.
Okay, higher likelihood means just oh, that's a good. Wait,
You're
that's
doing
deep.
something
So
that's
yeah,
Yeah.
into that. You're
this
doing
is
something that has historically turned into something,
yes.
and that's what you're choosing to do, and that's why you're.
I think I
higher likelihood.
Yes.
I think I can.
It has
Here's
cause.
And by
some of the
historically,
short-
what you mean is that if you look at a population, right, that a certain fraction of those
Sure,
people will develop the disease.
Let's let Zane wrap up. Let's let
Just-
Zane wrap
Yeah.
up.
We'll just turn this. No.
Sorry,
Oh, no. It's actually interesting. So, and I will weigh in a little bit. Is that one of the things that should be taught to doctors and is not is communication around risk, and the most effective method of communicating risk emotionally also happens to correlate with your insight there, which is to not use percentages, but to use natural numbers. And then the framing becomes, if I had 1,000 patients where I had the same amount of data as I do on you, this many of them would end up going on to get lung cancer or to develop hypothyroidism or whatever, right? By using the natural numbers, it puts a picture in people's head of 100 people, and then they can sort of start to say, okay, well, how do I feel about, well, one of them would go on to get lung cancer. Okay, I don't really care that much, right? Like, fuck that guy. But if 50 of them would, well, I have a certain emotional reaction, and that emotional reaction usually helps people make better decisions in risk by putting it in particular terms. Whereas percentages, first of all, are a little bit slippery for exactly that reason, and don't hinge on the notion of data. Is like, well, I know this about you, and this about you, and this about you, and this about you, and if I had 1,000 people where that's all I knew about them, this would be how that tended to break down as far as we know, right?
Yeah, and where I was going with that in general, if this is all clarifying, is that it really, the fundamental issue is a measurement problem. It's like, can I measure the causal sort of constituent in you as an individual, or can I only measure the correlative thing across a population?
Right.
And then my point is, what they're not measuring is the thing in you that either is or is not going to cause it. They're measuring the correlative thing across the population. And that's why, to me, the semantic, the thing that we feel when someone says you are at higher risk, doesn't feel quite right to me because it's misleading in that regard.
And I'm going to jump in there because it's a perfect segue to the next point. So the next point actually is, if I have, let's say, just fatigue, and I test with a TSH of 5.1, which is just over the old threshold, right? You can say, oh, well, you're hypothyroid. Maybe that's why. And what we would do is we would intervene, right? We would prescribe a thyroid supplement, right? And try to get this level down to less than 3.0 at the very least, right, as a target. Some people say 2.5, which I probably agree with. So, and then see how my fatigue responded to that intervention, right? So that is the final chain of causality where we try to say, hey, we have all these correlations, we have all these bell curves, we have all this fuzziness, we have all this, but if I give you a medicine and we get this down, then what happens to your symptoms? What happens to your anemia? What happens to your hair loss? What happens to your whatever, right? And that's our attempt to exit the correlative issues and enter causation issues. And of course, the problem there is the placebo effect. If it's just fatigue, how much of my improvement in fatigue was due to the supplement and how much was due to placebo effect, right? And again, for me, it's very difficult to know, right? For a population, we can make guesses, right? But for me, it's relatively difficult to know whether I just feel better because I'm being treated and I feel like something's being handled and I feel less tired as a result, right? And that's why we prefer some objective measures if we can get them, is hair loss or, like whatever. We try to get something that is less susceptible to placebo effects, though nothing's really completely immune from placebo effects.
To emphasize we don't know if it's placebo in that case, but to emphasize this idea that, anyway, for me, one of the most dramatic, potentially placebo-y stories is the stent story.
Yeah.
That study was...
Yeah, Orbita. So for those who know, the Orbita trial, they took 100 people that had greater than 70% blockage on an artery. So you had to have that to get into the study. They put them on a treadmill and did a stress test to see how far they could go before chest pain. They had typical angina, so chest pain associated with exercise correlating to ischemic heart disease. They took all 100 to the cath lab, went in with a wire, went up, looked at the blockage, sedated them, put headphones on them, and half of them to put a stent, the other half they came back out. They made sure the procedures took at least 15 minutes, so there was no differentiation in time. People were already kind of like hopped up, so half of them didn't remember it anyway, and then retested them, and there was no difference in the improvement in exercise time or pain control. And so for 40 years, we've been putting stents in stable angina, and it appears to have all been, in fact, the first stent ever placed was placed for that reason, and the guy became pain-free, and that's what started the whole stent thing, is the effectiveness of that treatment, which turns out to have likely been a placebo effect, which is phenomenal. Now, stents for acute, like if you're having a heart attack.
Placebo effect can be stronger for some people than for others. Right?
Of course, yeah. And we know, and again, population averages, the placebo effect of pills is less than injections, is less than procedures, is less than surgeries, right? And so there is a significant, and bad tasting things have a higher placebo effect than good tasting things. There's actually somewhat of a cost paid semantic in our minds subconsciously associated with.
If I had a negative experience, then I will be compensated with some treatment.
Improvement,
Okay.
yeah. I would not have done that if I were not, right, yeah, and so.
The one thing that violates that, of course, is ginger.
Yeah, of course, yeah.
Delicious also.
So, yeah, I think that the interesting thing about that is that you can't really do it with longevity effects. That's the real problem, is that, sure, if I have some symptom to point to, I can say, okay, well, I got better, right? I was coughing and had a fever, and then I took an antibiotic, and then I was not coughing and not dead, and my oxygen improved, right? You can draw a causal chain in the short term. But if you're talking about when someone died, the amount of confounding that comes into that final outcome, it's like, well, is it because they ate ginger, or was it the 10 other thousand things that were different, right? And seeing a signal through that kind of noise, given this level of fuzziness, is absolutely impossible. And that's why I get sort of like frustrated with the influencer set, where they're like, oh, your testosterone is only 400. If you got it up to 800, you'd live longer. I'm like, really? Because that's a bold claim. Like, I want to see, you better be doing a placebo-controlled trial for long enough to show that that is the difference, right? That I gave some people testosterone, I gave some people placebo, I somehow managed to blind them to the results for 30 years, and the ones I gave testosterone to lived longer. Because without that, you're just in this fuzziness making good sounding stories and claims that play on our cultural dream of being high testosterone, not real longevity in science, right? And so the few things, just wrapping up maybe, actually I'll mention and again, we kind of skipped over this, but I'll mention two other things. The other one is, no. The other one is the notion of interference or manipulation. So we talked about hemoglobin A1C, right? It's a measure of how glycated hemoglobin, how many sugars are attached to a hemoglobin molecule, which happens over time. It's interesting. It's the same reaction that happens when you cook a steak or grill a steak. It's the bonding of sugars to proteins. Happens faster at higher heats, but it does take some time. So at a low heat, it takes longer to get a good crust on a steak than it does at a high heat. That's because the reaction is slower, and just takes time. At body temperature, it takes a long time, but does progress slowly. The other factor is how available is the sugar. So if you want to get a really good crust on a steak, you can brush honey over it and put it on the grill. You'll get a better crust because you've made sugar more available to bond to that protein and increase the speed of that reaction, right? Same thing here. If your average blood sugar is higher, this glycation reaction will happen faster, and the A1C unit is percentage. And so a higher percentage of your hemoglobins will have an attached sugar, right? Well,
so you'll be at higher risk.
so you'll be at higher risk, correct? Some needling just across the table there. That's good, very good. So the interesting thing is, of course, you can do an end around, right? If you go, you have this amount of blood, right? And slowly over 3 months, which is the average lifespan of a red blood cell, it is being, a certain percentage of them are being attached to a sugar molecule, depending on how available sugar is in your bloodstream broadly over that 3 months. Now, if I go donate a liter of blood and then my body just makes fresh blood and then I go get an A1C, well, none of the fresh blood has a sugar molecule attached. It was just made fresh, right? And so I can
The
artificially,
reaction is slow in that regard?
very slow, yeah.
Okay.
Yep, at body temperature. It's kind of, it's like trying to grill a steak at body temperature.
Got
It's
it.
that
The
slow.
poor person who got your blood.
That's right. That's right. That's right.
So that was
Usually by the time you're donating blood, there are other issues there, but yeah.
So that analog was not the sort of sugar binding to the protein, on a steak was not as loose an analog to the glycate binding to a hemoglobin molecule in this case. Is what you're saying? The chemistry is more similar there than I realized.
It's the same reaction. Yeah.
It is the same.
It is the same
Oh,
reaction.
okay,
Yeah.
wow,
It's the
okay,
same.
cool.
Yeah.
Cool.
So you can manipulate this lab value, which is very predictive in its unmanipulated state, but giving blood donations does not reduce any of the risks of diabetes, right?
Or does it? As we give blood tests every day.
So separately, blood donation does seem to improve outcomes for men, but not women. There's some interesting indications of blood cell turnover. Menstrual cycle seems to be protective. Men theoretically used to bleed more, but anyway. But all that aside, it doesn't account for the degree of improvement in diabetes. Like if you have an A1C of 9 and you just donate enough blood to get that down over several months to 7, your blood sugar is still running in the 200 or 300s. Like you haven't actually changed the physiology, you just manipulated the test, right? Similar things can be
Still
said
gotta pay
for
tax, in other words.
yeah. No. You did this as a tax escape. Like that's the whole point. That's the whole point. And that's kind of one of those issues. All these, high biotin, high vitamin C throw off the lab machine. The way the lab machine does the chemistry detection will be thrown off by high concentrations of those molecules. So if you're taking a supplement for your hair or nails or immune system, or you're doing whatever, well, you're also throwing off the way the lab test works. So again, it's now not what was somewhat fuzzily reflective of the underlying physiology is now not even fuzzily reflective of the underlying physiology because you manipulated the test, right? And the last point I'll make before coming to somewhat of a conclusion is interactions between things. So this is the standard doctor's method of representing the electrolytes. So this is bicarb, and this is BUN, and creatinine and glucose is here. So this is the standard diagram we use so that we all know what we're talking about when we scribble it out. What's interesting is the pH is at least partly regulated by the ions, right? Potassium's a relatively low number, so it's in the 4 range, right? Sodium's 140, bicarb is 25-ish, chloride is 110-ish, whatever, the normal ranges. So these are much bigger, potassium kind of gets drowned out, right? But so sodium's positive, chloride and bicarb are negative, so you can subtract. So 140, just using my random numbers here, minus 110, minus 25, you get 5, right? And so that number is called the anion gap, and it is a measure of how many unmeasured anions are likely to be in your blood. Because if I give you a bunch of acidity, certain types of acid, your body will have anions that are produced to counter that, the base form of that acid, whatever that is, and this number will go up, usually by chloride going down, even though all these numbers may be normal in the normal range, that number will go above 12, right? And so all of which is to say, I recently actually had a case, kind of interesting, of a patient who was taking a bunch of ibuprofen. All lab values were normal, but if you did this addition, this number was right at the threshold of 12, right? And I was like, oh, you got to stop that. That's something is going off with your kidneys. It's not regulating the pH correctly the way it should. And so the last thing to say is we are able to make some inferences, however fuzzy that claim was, right? Based on the interactions between these, even though all of them are fuzzy, even though all the thresholds are fuzzy, and even though there's so much fuzziness, based on these patterns we're able to see of what they are likely reflecting in the underlying physiology, you're able to kind of make some predictions in disease states, right? Once you stop taking the ibuprofen, this did come back down. We had confirmed it. It was consistent. It came back down. She was fine. And again, we had a causal chain, right? Hey, it was high. We repeated it. You made this change, and it came back down. That was actually the proof. Otherwise, I was kind of like, I think it's that, right? But without that causal chain, you're really stuck. And so interventions, the ability to make an intervention and to prove that intervention works is tremendously important, which is why even for something like diabetes, as I said, like the lowest threshold is around 7.5 of mortality. And so getting, using meds, and nobody's ever done a study to my knowledge of getting people from 7.5 to 6 with lifestyle, because nobody wants to do that typically, but getting somebody from 7.5 to 6 with meds increases mortality, not decreases it, even though getting somebody from 9 to 7.5 with meds decreases mortality.
Makes sense. Now, just to maybe a similar note here. So I know the arcing.
Sorry, and just for thoroughness, that was with the previous generation of meds as well. So the latest GLP-1s and SGLT2 medications work very differently. They were not included in that study because that study is now like 7 years old, 10 years old. And so that may also no longer be true based on the type of intervention, right? So anyway, what was the question?
I was going to say this notion as it applies to longevity is clear. It's this idea that because we can't test, we can't have you die and then be like, okay, let's bring you back
rerun and run a different life.
Yep. Yeah, but even in this case, right? Even in cases where we can like test and get a value, to the points that were made previously, in general, right? The values themselves may or may not be indicators of the thing.
Correct.
And so there's even still that notion at play, I guess, is the idea.
Yep.
So like it's like on the one hand, longevity doesn't have this thing this sort of intervenable mechanism. But even if we have the intervenable mechanism, it's still not something that we can generally draw conclusions against, for sure. Because, for example, right, like the homocysteine example comes to mind. I can take a medication theory that will pull down my homocysteine levels. Yep. But the problem is that what it looks like is happening is that there is some other causal factor, right, in driving your homocysteine up in the first place. That's also the thing that's killing you. Yep. So just bringing your homocysteine levels down doesn't save you from the consequences of whatever the thing was that was giving you high homocysteine in the first place. Like just driving the levels down so even in this case, like you drove the number down, in this case maybe it does have a causally kind of an implication given the kidney, whatever. But in some cases, just driving the blood work down does not actually do anything for your actual longevity. Correct. Which is like basically it's even further in the evidence that longevity is a tough cookie.
And so going back to my testosterone, and actually I always use homocysteine, right? And the reason is it is very, very, very strongly linked to mortality and cardiovascular disease, right? It's a very tight linkage correlatively. But if you intervene and you lower someone's homocysteine, it has actually no effect on their mortality. Their mortality correlates to their original homocysteine level before you lowered it. And so many tests could work this way, where, hey, your testosterone maybe is linked to mortality. Great, it's a separate proof that intervening works. It's a separate proof that it's in the causal chain, not just a correlative chain. And that's why you have to do placebo-controlled trials. You can't just project out from, hey, look how strong this association is. It must be. It's like, no, it may not, it must not be. So yeah, that's a favorite example as well. The other,
I know it from you, to be fair.
Yeah, the other saving grace of a lot of these things is effect size, right? And that's another one, is that even homocysteine, when I say it's strongly correlated, like it's, you know, the risk of having high homocysteine is whatever, 1.1 compared to 1 or whatever, right? Whereas the lowest VO2 max, if you're a VO2 max in the 5th percentile, compared to the 95th percentile or greater than the 95th percentile, right? This is a 500% mortality change, correlatively, right? Now, the sheer size of that correlation, not in the significance, that's also some of the confusion. People say, oh, it's strongly correlated, like I did with homocysteine, meaning that statistically the correlation is strong. This is strongly correlated in effect size, like the degree of improvement in mortality from one to the other. Now, we also have separate evidence that moving people up the percentiles, that intervention does reduce mortality. So that's the other bit. Now, it probably doesn't reduce mortality by 500%. That correlation will almost always overstate the degree of significance, but it is a significant reduction in mortality. The studies have only been done in people with pre-existing heart disease because you don't have to wait 30 years. Their existing mortality is so high, you can see improvements within a shorter study, like 5 years. So again, applicability to the general population, you can get a little fuzzy on. But same thing for strength. Strength is like a 300%, right? And so it's unlikely that all of that is confounding just based on size of effect. Smoking is something like 180% effect on mortality, to give a frame of something that we all consider definitive in some sense, right? Social connectedness is like 150%, and like blood pressure control is like 115%. Cholesterol, if you squint at the data, might be 1.01%. So, again,
basically, no matter what your doctor says, just go to the gym and don't smoke.
I mean, honestly, if you go to the gym, you build up VO2 max strength and you don't smoke, like in terms of sizes of effects, you're so far beyond what any blood intervention can do